Thank you. Thank you for the introduction. Thank you, everyone, for the invitation to come speak with you this evening. My name is Beverly Tchang. I am an endocrinologist from Weill Cornell in New York. And before we get into the slides, which I think you may already be very familiar with, given what we've heard already here, I want to know a little bit about you guys. So with a show of hands, I'm just going to ask you kind of your specialty. And please don't be offended if I don't ask for everyone's specialty. But first, do we happen to have any surgeons in the room? One! Wow, a very brave man. Oh, and a couple more very brave surgeons. Thank you for joining us. And do we have any general practitioners? Yes. All of us, effectively, right? All of us, I understand. My favorites, any endocrinologists? Endocrinologists, right? One over here, thank you. And finally, do we have any cardiology specialists, cardiologists? Very interesting, okay. Well, I think the cardiologist would be the most interested in this data, but perhaps they have already been very aware of it, given that this is the medication that has transformed our cardiac care for these patients with obesity. So thank you for that. And I'm going to, I might go through some of these slides a bit briefly because I think something like this is very obvious, right? Obesity as an epidemic is an enormous, enormous problem. More than 250 million adults in India with obesity. Even if everyone in this room were to see 100 patients a day, we would not make a dent in this epidemic alone. I say if, but actually you do, right? You all do see 100 patients per day, and it still has been challenging to make a change in people's lives when it comes to obesity and on the population level as far as the prevalence of obesity. And this is because, as my colleagues had explained earlier, the disease of obesity cannot be treated with lifestyle changes alone. So for decades, we have pushed this narrative of eat less and move more. And of course, that hasn't worked, right? We've only seen the rise of obesity epidemic get worse. But because we now understand the pathophysiology of obesity better, we know that the treatment, just like any other chronic disease, requires both, requires those lifestyle interventions and something else that really addresses the biology of obesity. Why do we care so much about obesity? Of course, in of itself, it is a medical disease, right? But we're understanding now that obesity is the root cause of everything else that our patients struggle with. Diabetes, high blood pressure, high cholesterol, fatty liver, and cardiovascular disease. You see this in any way that you measure cardiovascular disease, whether it's coronary heart disease, strokes, heart failure, not shown here, but also arrhythmias, right? And so when we think about what single intervention can we do, especially when you're seeing 100 patients a day and you're maybe meeting them for 5 minutes at most, what single intervention can we do to address all of this list of comorbidities, all of the manifestations of heart issues? It's to treat obesity. And when it comes to obesity being its own disease, right, it doesn't need to have the complications of it to deserve treatment, right? We're not looking for people with obesity who already have type 2 diabetes. We're not limiting medications or intervention access to people with obesity who already have fatty liver. We're looking at a point in time in their disease state where you're actually at a position of prevention. We're not just treating a disease, we're preventing further complications of that disease. And this is why we want to be treating both those who have quote-unquote metabolically healthy obesity, right? No dyslipidemia, no dysglycemia, as well as, of course, those who are at higher risk. So we know that weight loss improves traditional cardiovascular risk factors. Weight loss is difficult to achieve and sustain due to the metabolic adaptations that we heard earlier. And yet, weight loss has not been an effective strategy for cardiovascular disease reduction. We know this from our landmark Look Ahead trial, which aimed for 7% weight loss over 13 years using an intensive lifestyle intervention. And yet, we still did not see a benefit in cardiovascular disease reduction in that trial. And we think it's because we saw an average of 7% weight loss in that trial. When we did a post hoc analysis examining to what degree of weight loss were we actually able to start to see the cardiovascular disease reduction, it was 10%. So really, our lifestyle therapies have failed in part because it just hasn't been able to access the degree of weight loss that we need sustainably to achieve that cardiovascular disease reduction. And when we look at our pharmacotherapy trials, so lifestyle intervention had failed, pharmacotherapy had failed up until now as well, right? You can see here a disappointing list of prior cardiovascular outcome trials or older pharmacotherapies for obesity that are no longer on the market. Sibutramine, rimonabant, lorcaserin was also removed from the market, though it did show non-inferiority for cardiovascular disease. So really, up until recently, we had an enormous need to prove that obesity management with lifestyle therapy and medications actually reduced cardiovascular disease. Enter SELECT. SELECT was transformative in the obesity landscape because all of the medications that we've used so far were really diabetes medications. We used liraglutide, often on label, to treat diabetes. We used to treat obesity. We used early on dulaglutide, off-label to treat obesity. And we had data from the REWIND trial. We had data from SUSTAIN-6. We had data from LEADER trial proving that cardiovascular disease reduction, but in people with obesity and diabetes. But in people who do not yet have diabetes, we had no trial to prove cardiovascular reduction yet. And this is why SELECT trial stands out as the only trial to demonstrate that, to test it and to demonstrate it. So 41 countries, over 17,000 participants, almost 500 individuals from India. This is the SELECT trial design, which if you're familiar with cardiovascular outcome trials, this is classic, just very classic, normal, boring cardiovascular outcome trial. At the very bottom left, you'll see what the primary endpoints are. This is what we call a 3-point MACE, major adverse cardiac events. If you look back at all of the other cardiovascular outcome trials, this was always the primary endpoint, 3-point MACE. So it gives us a good idea, a good way to contextualize these results. Cardiovascular death, non-fatal MI, and non-fatal stroke are those three points. And on the right-hand side, you see some confirmatory secondary endpoints. Baseline characteristics are, as you see here, largely male, older-ish than what we typically see in our obesity trials. So in the obesity trials, usually the average age is 51 and female. When you look at trials with greater disease burden, the diabetes trials, the cardiovascular outcome trials, they tend to be more male and they tend to be slightly older age. You can see the breakdown of the cardiovascular inclusion criteria, majority with a MI. So really the population we're hoping to treat the most. Mean baseline A1C of 5.8, so pre-diabetes range. Remember, this trial was conducted in individuals without type 2 diabetes intentionally. And a mean BMI of 33, and you see what the breakdown is there with the different categories of severe obesity. I think notably, almost 1 in 4 individuals also had chronic heart failure. And this will come back to us later when we're looking at some of those secondary exploratory endpoints to understand where else might these medications be helping our heart patients. I think what one intention was with these with GLP-1s was to look at what is their role in the current landscape, the standard landscape of treatment. We're not using it to replace statins, of course. We're not using it to replace any of your other cardiovascular protection medications. We want to see, can we iterate on what we're already doing really well? Can we add even further benefit to our standard of care already? And that's exactly what we recruited for the SELECT trial. Patients were on the standard of care. They were on platelet inhibitors, lipid-lowering drugs, beta blockers, the optimal medication regimen for cardiovascular protection. And even in those optimized patients, Wegovy demonstrated a further reduction in that 3-point MACE, a 20% reduction. When you look at the numbers, this translates to an absolute risk reduction of 1.5%, which may not seem that big of a difference, but when you're thinking about a population of 250 million people, right, and a degree of prevalence of cardiovascular disease in those millions of people, even just a 1% incremental level of protection saves thousands and thousands of lives. Okay. 20% MACE reduction. No other medication, again, obesity medication has demonstrated this. All right, so of course now Wegovy has earned its on-label indication here and at the FDA as not just an obesity medication, but also a cardiovascular medication. Cardiologists are owning GLP-1s, Wegovy specifically, just like they stole Jardiance or other SGLT2 inhibitors from endocrinologists. All right. So these risk reductions in MACE were evident actually very early on. So a post hoc analysis demonstrated that when we looked at the hazard ratio, that level of protection, it started to become statistically significant as early as 3 months in. At 3 months, patients didn't lose that much weight. There was about maybe 4% weight loss at that point, and they weren't even on the maximum dose. So we're understanding this medication's mechanism as not just causing cardiovascular protection through weight reduction, but perhaps weight-independent reductions. It showed consistent benefit across all of the other secondary cardiovascular outcomes. I'll point out here that one of the secondary outcomes that they examined in a hierarchical manner was cardiovascular death. And interestingly enough, you'll notice that the confidence, the reduction so this one actually, shows the reduction all-cause death. Cardiovascular death didn't actually show a significant benefit when they tested that, but when they looked at other secondary exploratory outcomes, all-cause death was also significantly reduced. So you see that list of secondary outcomes here, notably the all-cause death, and interesting trends for those composite heart failure outcome, cardiovascular death, the expanded MACE, non-fatal MI, non-fatal stroke. What this forest plot really demonstrates is a clear directionality of the effect of this medication. All right. So in summary, Wegovy was associated with a reduction in multiple cardiometabolic risk factors, about an 11% reduction in weight, which is significantly lower than what you might see in the obesity trials of 16.9% that the STEP 1 trial was just presented for you. But even then, even with that 11.7% weight reduction, we still see 20% reduction in MACE, as well as additional improvements in your cardiometabolic risk factors. I mentioned earlier that Wegovy is really, you should think of it as a prevention type medication. So we see that when we look at the number of individuals whose diabetes were prevented from progressing. Sorry, their pre-diabetes was prevented from progressing to type 2 diabetes. And so we see that on the left-hand side. Whereas those in the right-hand side on placebo, more individuals, of course, progressed to diabetes. So really, overall, SELECT trial is our success story for obesity medications. Finally accessing that level of weight loss where we would expect to see cardiovascular benefits. And the additional bonus to that is showing that cardiovascular benefit early on, even prior to significant weight loss. In a real-world study called the SCORE study, we see this play out in real life. Okay, so 20% reduction was actually observed to be a 42% reduction in this real-world study in that 3-point MACE. And I think I'm at time, and so here's our summary, and thank you very much.